So this case, so 30, unusual, isn't it, at 30 to have consider a TAVI? Well, it would be very remiss not to introduce Philip Abora, who's in the room as well. So although not general anaesthetic, I mean, there's a good discussion point there to be had about is the anaesthetist required or not. I myself find it very comforting that Philip is here because sometimes TAVI becomes a little bit more sporty and having someone focused on maintaining the patient while we try and get the valve in is always a good idea. So, so this case, so 30, unusual, isn't it, at 30 to have consider a TAVI? The two choices are put a metal valve in now, and that requires, at the age of 30, warfarinization, not a DOAC, and then a redo operation if between 30 and 40 years, so he's 60 to 70 at that stage, and it's committed to redo surgery at that stage. That surgery will be surgery number 4. He had an initial endocarditis. He was born with a VSD, had initial endocarditis, had his homograph root and a valve done. 12 years later, he had a redo operation because he had severe aortic regurgitation and a 25 perimount valve. And 12 years later, he's now got severe aortic regurgitation and presenting in a little bit of a heap coming back from a skiing holiday. So initially he stabilized, but this really is close to an emergency TAVI because he was into timetable for Monday. This is a Friday, and we really didn't think that that was going to be a good idea. The renal function's going off, the liver function's going off, the sodium's going down, all the signs of a low cardiac output state despite a blood pressure that was reasonable. So when we had a chat at both our MDT and at the ACHD MDT, then the consensus was that redo surgery, 10 to 15% mortality. TAVI, I think, will be a 1 or 2% mortality. And whatever we do, there'll be further interventions planned for the future. And with the LV now at about 20 to 25%, perhaps picking up to 30 with a bit of diuretics, with the RV not quite normal. Clear consensus to go for TAVI, but so that we've got a femoral shot. You can see a little bit of something just at the edge, and I think that may be a spasm, but it's decent size arteries. What we are aligning for is the valve, and your posts are right. Do we need a pigtail catheter aortogram? Well, CT scan shows the coronaries are miles away. That's not a concern. So I think we've got a great position for both crossing and actually deploying the valve. The valve in valve app says in this 25 millimeter perimount, we'll put a 26 Edwards. The question is about cracking. There's a global shortage of true balloons, and we actually don't have the correct true balloon. But my guess is the hemodynamics are going to be fantastically better. So we could get a better gradient out of the Medtronic valve, but the problem then is the redo operation because the valve can get embedded in the aortic root, and this aortic root is already not normal. It's a homograft. Okay, so
it's just lucky. There we go.
Okay, lovely. Shall we go to RAO to get the apex? And I think, again, some centers don't do routine hemodynamics. I must say, I find that nerve-wracking as well. So I'm going to flush both ports and then re-zero. So if we look at those hemodynamics, then we now understand why the sodium's going down, the renal function's going off. The gap between the aortic diastolic pressure and the EDP is like 0. And so I think this is where, well, we're going to see a big difference when we measure at the end. So we've got a remote sensor on the pacemaker he's got already. It's a Medtronic device. So we're going to, you're going to feel your heartbeat race a bit. That's us. Okay, don't worry about that.
Pacing on? No. It's not great.
Stop. Well, try 200. Okay, I think that'll be good enough. Yeah. It's not going to move, but can we give it a 200? Far away. That's fine. That's fine. Stop.
200.
Okay. We'll do that one more time when we've actually got the valve in position. Okay. We're just testing that we can use that. Okay.
You got the wire? Thank you.
Yeah.
Okay.
Bit of pushing in your leg. Okay. Don't worry about that.
It's fine. Okay, Iqbal.
Okay.
Yours.
Super.
I'll hold this. There,
that looks good. Yeah, that looks very good.
Yeah, we'll just do very slow inflation under rapid pacing.
So
we'll just take a picture of that.
That's a good position. And once pacing on, ready?
And
I'm
balloon
going to start.
Up. Yeah. Slowly, slowly, all the way, all the way, all the way, and balloon.
Hang on.
All the way, all the way.
Valve.
Fill it, fill it, fill it. All the way. It's quite a long pacing run, and balloon down and pacing off.
Okay, so I must say I always then do this because there's been a drop in pressure and sometimes the reaction is to the legs to go up, and that can produce a tear in the blood vessels as the sheath is big. So he hasn't actually moved, but we can predict that it could happen, and there's no reason not to just press. I actually deliberately locked it so I could deploy the pressure. I think a hand push is never good enough, but I'm tempted to just double dip.
Yeah. And balloon up, Iqbal, all the way. Balloon, balloon, up, 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 up,
I'm going to
up,
empty
all
this
the
time.
way, all the way, all the way.
Okay,
Well
and
done.
down.
Balloon down and pacing off, please. Very good.
So can we compare that picture to the one before? So I think it does look a bit wider. So we go to that one, and then we go to the next one, the next acquire. So I think it's does look a bit more pushed out. And I think the double dip is probably going to be enough. I don't think we're going to be doing anything more to this. So
let's measure
let's have the
gradients and
picture.
hopefully it'll be okay.
So the first time I did the standard inflation, and I'd already got 1 extra mil in. The second time I've given the extra mil and obviously locked to make sure we can get to the right pressure. I think hand injection will never be enough. We're not strong enough. These atmospheres are sort of higher than car tire pressure, so I don't hand pump my car tire, and neither can I do a valve like that. I think we're going to see a phenomenal result here. So 0 both. Okay. Thank you. So let's focus on this. And so
very good.
So to be honest, what's looking like is that there's a tiny gradient, but the key feature of this is the aortic diastolic pressure and the EDP. The EDP is now 15 or 10 to 15. Aortic diastolic is 60, and there was practically no difference between them before. And I'm always amazed because there's a few cases we've done like this, that the patient is actually walking to the bathroom with no coronary perfusion pressure. Gradient, mean 17, peak to peak 25. Well, I mean, I think there is a gradient, okay, and sadly we don't have the correct cracking balloon to do it. I think it's pointless to put a 23 true, which is what we have available, in there. It won't touch the sides because we've already made it much bigger than that. It's a 26, and the 26 balloon is almost fully inflated. Can I just see the balloon inflation, please? The second one. Second balloon inflation. Here we go. So I mean, so
it has
20,
expanded. It
yeah.
expanded
So
as well
I
as
think
it
this
could
is
be.
this is acceptable. I mean, this is a semi-emergency TAVI, and I think we've got a great rescue of him. I think his LV will probably pick up. I think his RV will hopefully pick up, and he can end up with a more definitive procedure in 5 to 10 years' time.